yourself to everyone?
Yeah, thanks, Molly, and thanks to BUSOG for inviting me today to share my experience of caring for pregnant women in the time of COVID. So hi everyone, my name's Nimarta and I've just finished my foundation training in London. I started on my OBGYN rotation in December last year and I was due to rotate 4 months after. But because of the pandemic, I stayed on for the last 8 months and I will be starting my OBGYN training as a ST1 in London in a few weeks' time, which I'm really looking forward to.
So first of all, how did the obstetrics department at your hospital first react to the outbreak of COVID-19 in the UK?
Yes, it was actually very impressive how quickly the department acted, especially at the beginning when things were very uncertain and felt a bit confusing. And the first thing I think they did was a structural reorganization of the department to improve patient flow through the department. So in terms of that, what they did was they converted a few of the side rooms on the antenatal ward as well as labour ward that were to be used specifically for COVID positive patients. And these side rooms were located close to the back entrance so that we could ensure that women who were query COVID or COVID positive were coming in through there rather than the main entrance, where they would be greeted by a midwife and taken to their respective rooms for treatment. What they also did was they converted one of the labour ward side rooms to a COVID positive theatre, and that was to be used for women who were COVID positive and were needing a category 1 cesarean section, so urgent delivery with immediate threat of life to mum or baby, because of the possibility that it could be converted to a general anaesthetic, making it an aerosol generating procedure. So the reason they picked a separate theatre to be used for that reason is firstly because it would take longer for them to deep clean the theatre after, and they wanted to minimize any disruptions for other patients needing to go to theatre, but also secondly because there were 2 utility rooms on either side of this theatre. So one was a clean utility room where you would go in before the operation to don on your PPE, and that same room was used to transport baby out of theatre into a different room so that we were minimizing any exposure of COVID to the baby, and they could be assessed in a separate room by the midwife. And then obviously there was the dirty utility room where we would come out of theatre and don off our PPE. All of this was recorded into a video and sent out to all members of staff very quickly. So throughout the whole time at the beginning, I felt like I was prepared for what was to come, and that the seniors in the medical team were taking on the responsibility of communicating with their juniors, as well as members of the multidisciplinary team, midwifery teams, and the anaesthetic teams. So I think that was the first sort of reorganization and big change that we had.
Perfect. And what other changes came into place and how did that affect your practice?
Yeah, so all of the changes that came into place were patients were having to make to the hospital. So I'll list a few. So firstly, the early pregnancy unit ultrasound scan slots were increased to allow extra time for cleaning of the machines and the room after each patient, which obviously had the intended effect of increased sanitization, but an unintended consequence of meaning there were fewer scan slots per day for us to be able to scan women presenting with any complications in early pregnancy. And to combat this, every referral that was being made to the early pregnancy unit in the time of COVID was being telephone triaged by a doctor to, for example, if a patient was 11 plus few days in gestation, a history was taken on the phone to see whether they could safely await their dating scan, which would be due when they were 12 weeks, or whether we needed to bring them in more urgently and give them an appointment either for the same day or the next day. So there was a rationalization of scan slots in that manner. Secondly, there was a change in the way in which we were conducting antenatal clinic appointments. So as we know, routine antenatal care is essential to detect the common complications in pregnancy, such as preeclampsia, gestational diabetes, as well as asymptomatic urine infection. So the RCOG guidelines have advised that even in the time of COVID, there were a minimum of 6 face-to-face appointments with women. And some women will have a medical or an obstetrics complication, which means they need additional appointments or the input of the multidisciplinary team. And in that instance, their midwife will refer them into hospital to be seen in the antenatal clinic by an obstetrician. And in the time of COVID, the consultant who was looking after these women would triage the reason as to why they're being referred. And if these women were not requiring any blood tests, any urine test, or measurements of their symphysis pubis height, these appointments were being converted into teleconferencing appointments. And I was conducting these telephone antenatal clinic appointments. And with 55% of communication being body language, I was really starting to miss seeing patients face to face. But it was an instant change that I think made a big difference to minimize the number of times women were having to come in, because a lot of them were very anxious about coming into hospital anyway. And if, for example, some of them had issues with their blood pressures, they were being issued a validated home blood pressure monitor with instructions about when to take the blood pressure, how to do it, as well as specific cutoffs for the blood pressure about when they should seek medical advice. So that was also limiting them from needing to come into hospital for monitoring of their blood pressures. And as a lot of us will know, another change was that birthing partners were allowed when women were on labour ward, but they were not allowed in antenatally or postnatally, so to come in for scans or clinic appointments, or to stay with mum and baby after delivery, which had a huge impact on our women. Another change was, so in hospital, after women had delivered, we were providing them with postnatal contraception before they were being discharged. And that had a huge implication to reduce the risk of complications that result from a short inter-pregnancy interval, but also termination of any unwanted pregnancies. And because we were offering them in hospital before discharge, it was prompting these conversations early on in the antenatal clinic, so women had time to consider their options and think about which contraception they would like, if any. And so if, for instance, a woman would pick a intrauterine copper device or an intrauterine system, this could, and they were going to be having an elective cesarean section anyway, when we were consenting them for the elective cesarean section, we were also consenting them for insertion of these devices intraoperatively. So it would prevent them having to see a family planning clinic or the general practitioner 6 weeks down the line to have that inserted. If they were opting for a progesterone-only pill, we were giving them 6 month supplies, so they wouldn't run out and wouldn't have to see make another visit to see a healthcare professional to get more of that. And finally, the bit that was most exciting for, I think, us trainees was we were also inserting implants on the ward before discharge. So I was trained on how to insert implants, and I was able to put them in for women. On the note of postnatal contraception, I was really interested in seeing how this was making a difference to women's quality of care that they were receiving. So I set up a questionnaire to sort of understand how they felt about having immediate access to postnatal contraception. And that was all very positive. And so we're hoping for that to be something that continues even after COVID, so to try and secure the funding to provide them in hospital.
Next up for you, Nimarta, is you mentioned about birth partners not being allowed outside of labour ward. What were the challenges faced because of it?
Yeah, so huge. And I think that was probably what was upsetting for most women in terms of the changes that came about because of COVID. I can remember 2 distinct cases off the top of my head. So first off, it was leading to a difficulty in translation because I had a woman present for a review postnatally, and she was complaining of offensive smelling vaginal discharge. And ordinarily her husband would attend with her to be able to translate for her. But obviously he was not allowed in, so I was using Language Line, which is the software that we use to obtain translators on the phone, and she quickly told the translator that she would like her husband to translate for her. So we ended up calling her husband on the phone and having him on speakerphone translate for us, and understandably he was very frustrated that he wasn't able to come in and be there with her. And it made obtaining consent for sensitive examinations like speculums a little bit trickier, and took a bit longer to be able to take that consent over the phone with the help of a translator. So I think that was something that was frustrating for members of staff and patients when we couldn't just have the partners come in to translate for us. And secondly, I think there was a huge impact on the lack of support that we were able to get from their partners. I was on a night shift when I had a patient present. It was her first pregnancy and she was about 35 weeks pregnant. So she wasn't term yet, but she was complaining of her waters having broken. And on history and examination, a rupture of membranes was confirmed, and she was understandably extremely anxious about the implications that would have about going into early labor on her baby. And it was heartbreaking to say no to her when she kept asking for her husband to be able to come in just for a few minutes to comfort her. And so that was really difficult. And as much as I was able to try to console her about it being a good prognosis at this stage, and that our neonatal team were well equipped to be able to handle babies at that gestation, and they would come and talk to her about the implications as well. It was very difficult to console her, and I think her partner would have been able to do that a lot better than we were as a team. But because of the change that birth partners were not allowed to come in, we introduced another change in the way in which we were inducing labour. So NICE guidelines has always recommended first line to be a pharmacological method by administering prostaglandin E2 as a method of inducing labour. But during the time of COVID, we were converting that to a mechanical method of induction using a balloon insertion into the cervix to provide that mechanical form of trying to induce labour. And there were two main reasons for that, really. So firstly, the pharmacological method of inducing labour is generally a lot more painful for women. And so because they were not allowed to have a partner in with them, we were trying to minimise them having to go through that pain on their own. But also secondly, depending on the women's risk factors, any lack of concerns from the obstetrics team about the woman or the baby, some of them were being allowed to have the balloon put in and to go home overnight to come in the next day. So that was beneficial as well. They weren't having to stay in an extra night on their own on the antenatal ward. So as much as that was a very difficult time not allowing partners to come in, there were things that we were trying to do to combat that as to the best that we could, really.
Did you have any patients who had complications due to COVID?
Yeah, so the women that we saw generally with COVID were well, and after we introduced testing for COVID for women who were coming in for elective cesarean sections, or who were coming in for induction of labour, which were planned, we were testing them for COVID before they were coming in. And so we were having a lot more asymptomatic women being picked up who had COVID. But another indirect complication, not per se because of the impact that COVID has on us, was about medical abortions. So obviously to be able to allow women to continue to have medical abortions safely, those that were choosing to have medical abortions were being able to receive the medication in the post to be able to do that at home, so that they were not deprived any access of services. But because of that, if they came into hospital with complications of that, like heavy vaginal bleeding or abdominal pain, the assessment was a bit trickier because there was no scan before they had the abortion to tell us for sure that the pregnancy was intrauterine and they didn't have an ectopic pregnancy, for example, which we would have treated differently to if they came in with pain and bleeding with a confirmed intrauterine pregnancy. So that was another complication that I guess we saw in COVID times.
What are the current restrictions for pregnancy-related care, and how do you feel about them?
So fortunately, like I was saying, the main sort of change that negatively impacted the quality of care women were receiving were birth partners not being allowed, which now they are able to come in and visit on the antenatal and the postnatal ward. And every unit will vary as to where they are in terms of introducing services back to baseline, but I think the department that I work at is nearly almost there. The thing that we're not at speed to at the minute just yet is being able to offer everyone a scan in the early pregnancy unit. So for example, if someone is pregnant and is 5 or 6 weeks along in the pregnancy and they describe vaginal bleeding or abdominal pain, the main differential that we would want to rule out is an ectopic pregnancy, which would be life-threatening. So we would offer them a scan to ensure that the pregnancy is intrauterine. But in a small percent of the cases when we have confirmed the pregnancy is intrauterine, but we're uncertain of the viability of this pregnancy, because it could just be too early to visualize what we need to see, or what we see doesn't match the dates that the patient says their last menstrual period was on. So pre-COVID, we would have offered them another scan in a week's time for reassurance purposes. Whereas now, because the diagnosis is clinical, a few weeks down the line as to whether the pregnancy is ongoing or whether there are any signs that the pregnancy is failing, we haven't yet got to the stage where we're able to offer a reassurance scan a week down the line. And that's something that I hope over time we manage to be able to offer again, for the benefit of reducing anxiety that the mum and the birth partner have, rather than awaiting events, if any, to suggest a failing pregnancy.
First one is, was there any extra support given to trainees who were working during such a stressful time?
Yeah, absolutely. So all of us in the department had our risk assessments performed. So we were able to, if there were any reasons as to why we couldn't work or working from home was preferential, that was definitely encouraged. Most of us also had chat to our supervisors about how we felt about things, and I think the emotional support was there in terms of excellent communication from the consultants to us. If there was any talks about redeployment, so moving me from OBGYN into ITU or medicine, we were always told and kept up to date about what things were looking like. So for instance, in the first week, there were high chances that we were going to be redeployed, and they had told us that. And a week down the line, because medicine had managed to get on top of, or at least in our hospital, on top of things with the staff they had, we were told we weren't going to be moving just yet and kept put. So a lot of options were offered to us in terms of working from home, any risk assessments, any challenges as to why we felt we weren't able to come into work. And generally everyone was very supportive if you had to self-isolate or if you developed symptoms and had to go home.
Is there any particular trimester when COVID-19 is more dangerous to the mother and baby?
So obviously there's limited information about the effect of COVID-19, but from what we had seen, there was no increased risk for a pregnant woman compared to a non-pregnant woman of the same age, medical comorbidities. They were not seen to be affected more badly by COVID. There was also, last I checked, there was also no evidence as to vertical transmission from mum to baby in terms of baby getting COVID. The steps that we took to prevent that was just, as I said, if they were delivered in theatre where an aerosol generating procedure was performed, the baby would be moved into a different room to minimize any risk of exposure. We were not discouraging women who had COVID from breastfeeding or seeing the baby if that's the choice they made, that they did want to breastfeed and see baby, because as per the RCOG guidelines, the risk of not forming attachment to your baby and not bonding in the first week was outweighing the evidence that we had about transmission.
And did you find that more women were coming in with more severe pregnancy complications due to avoidance of seeing the doctors earlier out of fear of COVID?
And so from speaking to colleagues that were working in other departments, that was definitely the case. But patients that I had seen, I had not found that to be the case. And I think that's because we've got a separate triage system. So in the maternity unit, we've got a triage department that is manned by a midwife 24/7. So women are always encouraged to phone in if they had any concerns. And so because they had that access to 24 hours support, they were always calling and giving advice either to come in or to stay put based on the symptoms they were describing. So if there was any symptom that they had described that meant that they needed to be seen, we would advise for them to come in, and they were coming in on that instance. So I think we were fortunate in that because our patients had that access to medical advice and support all the time, there was less risk of them missing out.
Did spending more time in obs and gynae than initially anticipated affect you wanting to choose the specialty?
No, so I've wanted to do obs and gynae since medical school, and I also took a year out to do a master's of research in obs and gynae related topics. So I had picked this F1 and F2 rotation with the intention of having a 4-month F2 block, and I'd actually got a training number before I was told that I was going to stay on. But it did have a good impact on my training, because now I feel ever so slightly more prepared for starting ST1, having had 8 months experience versus the 4-month experience.
Lovely. And practically, how did you work with other specialties who are relevant, such as ITU? I think they meant respiratory and general medicine.
So this specialty wasn't mentioned, but in particular, I found working in radiology very helpful. So if we had, because where I work, the maternity department is in a different building to the main hospital, things like getting a scan, ordinarily we get porters to take them across the building. But I have to say radiology in particular were very good at coming to us, although we were in a different building, to perform any scans or x-rays on women that were COVID positive and whom we needed any investigations. They were also coming for bedside ultrasound scans. If we needed an ultrasound abdomen, for example, they would come to us to do that. In terms of liaising with the intensive care, we had a dedicated obstetric medicine team comprising of 2 consultants and 3 or 4 registrars, and they were going over to ITU every day to see the patient that we had in ITU, and then updating one another on the progress that the patient had made in the few days. So I think there was good communication and they worked well together. Other than, we didn't have anyone with COVID who needed to be on a medical ward for respiratory support that didn't need to be intubated, if you see what I mean. So we didn't have any pregnant women that were going to the acute assessment unit for respiratory support.
Thank you. And do you feel that there will be a lasting impact on maternal health from things like trauma from the lack of support during birth?
It's too early to say from actually speaking to women and seeing what their experience is like down the line, because obviously we're still early on in the pandemic. But I would think so, from what they were saying. Particularly the case that I mentioned actually really got to me, because it was so hard. She kept asking for her partner to be able to come in, and I had to keep saying no. And I went to the midwife in charge and I was like, is there any way? And understandably they were like, it just would be unfair to everybody else that was in here. So I think yes, in the long run there probably will be, but hopefully what we've done to combat that, so changing things so that we were making things a little bit easier. Obviously we couldn't replace the fact that they weren't allowed partners in, so we were for example in scans we were encouraging them to take a 10 to 30 second video at the end to be able to show their birth partner when they get home. And I, for one as well, when I was seeing patients in the early pregnancy unit who had unfortunately had a diagnosis of miscarriage, if they had asked, can I call my partner and put them on speakerphone so they can listen in and ask any questions, I was always encouraging that and allowing that as well. So I think as healthcare professionals, we were very understanding of the fact that this was extremely difficult and not what they had expected was going to happen, of course. So trying to be accommodating of any requests that they were making. And for example, the ITU patient, so she was being when we were taking photos of baby and passing on any messages that she had for her partner and vice versa. So there was a midwife who was sort of liaising in between the partner and the baby and the mum, so the partner wasn't losing out on being able to see pictures of the baby while the baby was admitted with us.
Did women labour with masks on, and was this difficult in terms of communication?
So we never insisted for the women in labour to be wearing a mask. If they were wearing it, it's because it was their choice and they felt more comfortable wearing it. And in fact, majority, I think, of the women that I had gone into who were in labour weren't wearing a mask at the time. Their birth partner was always wearing a mask, and we had to do a formal declaration of health from the birth partner to ensure that they hadn't had any symptoms or any contact with anyone in the last 14 days. But the rules of wearing a mask were not enforced on the mum.
How were births facilitated in terms of minimising the separation between mother and baby in infection control conditions?
So, like I was saying, so in the postnatal ward, there were side rooms that were specifically dedicated to women who were COVID positive or had had COVID. So that we weren't, so A, they weren't in an open bay, but also B, they were close to the entrance or exit of the department. So they weren't having to walk around the department fully, minimizing the risk of spread through the department.
As I can see, there are a lot of questions about careers, which is really great, but we're going to have a separate careers event. So at some point, so if you could save those questions for them, then that would be really, really great. Next one is, how did the mothers and families respond to the extra precautions you had to take?
On the whole, everyone was very understanding. I think there was only one family that I looked after where it was a little bit challenging to explain to them that the partner was not allowed in with them when they were coming to the maternity assessment unit for triage. But personally didn't face any difficulties with them understanding that they were not allowed in the unit, and everyone was very understanding and appreciative of, during the time anyway, of everything that we were doing to keep their partner safe, that there weren't any that I was aware of.
And the report about people of BAME backgrounds being more at risk from contracting COVID-19 came out. How did this reflect on O&G wards?
Yeah, so there's obviously two sides. So there was staff and then there was patients as well. In terms of staff, the assessments that I was talking about initially were all reconducted on members of BAME backgrounds to ensure that their risk had not now changed because of those other risk factors. And in terms of patients, community midwives who had patients that were from a BAME background were advised to, on their next visit, to go through the risk factors with the women again, and they very quickly developed a new leaflet for women who were BAME to be able to give to them to explain that they were at increased risk, and the increase, almost everybody should be taking the precautions anyway, but almost the increased need for them to be taking the precautions of social distancing, hand hygiene.
Do you think that they should permanently switch to having mechanical induction as like the first line?
Yeah, so there's at our department is actually an audit going on at the moment, both in terms of how effective it was as a method of induction, but also a patient experience quality improvement type project to see how they felt with the balloon. Because although with the pharmacological induction, there is increased pain because you get the false sense that you're having contractions. In terms of the mechanical induction, in the beginning, when we put the balloon in and we inflate it with saline, we were trying to inflate it up to 80 mils, and now that's a lot of water to be able to be putting into the balloons to extend the cervix that much that quickly. So in the initial hour or two, it was quite uncomfortable for women to get used to that feeling that they were having down below of the extension. And in terms of success rates, we, as a team, just seeing patients but without any hard data, felt that it was more effective as a method of induction. And the only challenge with the balloon induction was that not many members of staff were trained in insertion of the balloons. So there was a delay in us putting in the balloons, because if the midwife on the ward, for instance, was not at a band where she was able to insert the balloon, the patients were having to wait for the obstetricians who were on labour ward to be able to be free to go over to insert the balloons. So I think at the moment the plan stands that we're going to audit this more formally to have more data other than the anecdotal data that we have amongst one another, to get more information on how patients felt, particularly about getting used to it in the beginning. And then I think there's plans to maybe start almost like a research project to see whether it would be as effective if we put in maybe 60 mils of water in the balloon rather than the 80, to check whether that helps, before we decide that we want to convert to balloon inductions entirely. And if that's something that we decide to do, then we would have to increase training for members of staff, for more people on the wards to be able to put the balloons in. Another thing to say about the balloon, I don't know if that's too much information, but with the balloon, when you insert it into the cervix, there's a risk that you displace the head. So if the head is engaged in the pelvis and you're putting the balloon in, sometimes you might push the head up further ahead, and then you might have someone with an unstable line where the baby is moving between being cephalic, so head down, and turning sideways to being transverse, so across the abdomen. So that was one of the negatives of using balloon inductions. That's something that we would also bear in mind before converting to balloon inductions for everyone.
Been a lot of news about women being delivered news about miscarriages alone in clinics/wards. What support, if any, was provided to them during COVID?
For women who were being given diagnosis of miscarriages.
Yeah, so I suppose it's like a Breaking Bad news. Was there anything additionally added, or was it just the same?
Yeah, so personally, as the doctors who were seeing them after scans, because there were fewer scans being done, there were fewer patients to be seen. So I had a lot longer to counsel women through their options, and I had more time to be with them in the room to offer them the support that I otherwise maybe wouldn't have had if the appointment times were shorter. But also, secondly, we had a separate quiet room. And so if women were extremely distressed, even after their consultation with myself, we offered for them to go into the quiet room to just have a glass of water, a cup of tea. And in those circumstances, we were very occasionally allowing partners to come through the other entrance to go straight into the quiet room, because we weren't using that for every single patient. So if they had been in there, we had the time to deep clean the quiet room before another patient went in. And like I was saying earlier, we would always offer them the option to call their partners in, call them on the phone while I'm talking to the patient, to be able to offer them the extra support. But it was a difficult time. It was not easy to break that news as well, and trying to maintain sort of the doctor-patient relationship, because I'm the one that's breaking the bad news, and as sensitively as I'm doing that, usually there's a partner there to provide the emotional support while I provide the medical information about how we're going to manage them and the options that they have. So it was definitely very challenging.
Did you take on any responsibilities / got new skills that you wouldn't have typically gained as an F2?
Yeah, absolutely. So one was training in implant insertion, and that's something that ordinarily is quite hard to obtain, because you have to have a diploma from the Faculty of Sexual and Reproductive Health, which I was hoping to eventually do, but I was able to start putting the implants in. Generally, all the gynecological clinics were converted to virtual clinics, and all the elective gynecological operating had been cancelled. So there was more time for me to not be doing the gynecological procedures and to spend more time in labour ward. And particularly as I'm going into training, and in ST1 and 2, your main aim is to be competent on labour ward, to be the first on-call registrar as ST3. It was very useful that I was able to be on labour ward more, because I can always pick up the gynecological gynecological skills as I go ahead in my training, but the main focus in your initial years in training is being competent on labour ward. So I got to do that. Obviously, like I said, got to stay on for another extra 4 months. And so I was assisting in a lot more cesarean sections and felt confident to close at the end of a cesarean section, and I don't think I would have been able to do that just at the end of the 4-month period.
What would you say is the biggest takeaway for you from the last few months going into your further training?
I think it just, all of that extra time that we had, like even seeing patients in the early pregnancy unit, being there for women because they didn't have their partners when, for example, the lady who went into labour early, just made me realise how much patients appreciate you being there for them and being able to offer them the support. And we're always busy. There's always another patient to see. You don't have the time that you'd like to spend with them, but in these unusual circumstances, be able to give them that extra time and then seeing how much they appreciated you spending those extra 5 minutes with them, going through things slower, or even just sitting there in silence with them because no one else is sitting there with them, is something that I'm going to take with me going into training. And I think as much as I'd love to be able to do that with everyone, I think I'm definitely going to be more conscious of it, to try and do that and not be rushing to see the next patient, which is what I think life was like before COVID.
A good one to wrap up on is, do you think working as a doctor during COVID has reassured your decision to pursue obs and gynae? If so, why?
So I think working as a doctor in COVID definitely made me question medicine a little bit more. You know, we were going into work every day, not putting our lives at risk because I'm young, fit and healthy otherwise, but definitely putting our health at risk, because if you did have COVID, you were going to be poorly and off sick, even if it was with cold symptoms. So it made me think, this is something that I really, really want to do, and that's why I'm going to work every day without that feeling of I'd rather not be here. So I think it affirmed my decision for doing medicine, definitely. And in terms of specifically for doing obs and gynae, definitely helped that I had more clinical experience to ensure that, you know, I 100% knew what I was getting into before I was starting.
Perfect. Well, thank you so much for coming on. It was so interesting. I'm sure everyone else found it incredibly rewarding. So yeah, thank you very much. Is there any